Chapter 16, Health Problems for School-Age and Adolescent Children. So we're going to first talk about elimination, and enuresis is bedwetting. So this is after a child is potty trained, they still wet the bed at night. This is more common with boys. Most of the time they get over it between about 6 and 8 years. Parents will tell you that their child who has enuresis is a really sound sleeper, that they feel like the child just doesn't wake up when they void and doesn't wake up to the sense of needing to void. And if you ask about the family history, you'll usually find out the parents also had the same issue, strong family tendency. So some of the ways we'll try and deal with this is restricting their fluid in the evening, nothing to drink after dinner time, and eliminating sugary and caffeinated beverages after 4 p.m. Many parents will interrupt their child, wake them up, and make them get up and void during the night. There are bed alarms that you can buy that cause a conditioned reflex. So as soon as the child starts to void, the alarm goes and wakes them up so that it develops a sense of feeling, oh, I'm about to void, I need to wake up. And then hopefully they wake up and can go to the bathroom. If none of those things work, we can use some medications either to decrease the amount of urine they make during the night, which is the DDAVP, or just make the bladder less active during the night. Another problem with elimination is CAPRISA. So this is stooling. It's defined as repeated voluntary or involuntary passage of normal feces, so it's not diarrhea, into inappropriate places. So this is the kid who cannot control their bowel movements. So it cannot be caused by a medical problem or medications we give them like laxatives. Again, more common in males. This does tend to have a psychological piece to it. So usually what happens is the child is constipated or impacted. It hurts when they pass a stool, so they hold their stool. It's intentional withholding because of fear of pain, but by withholding that stool, it becomes larger and harder and very painful when they go. And so it reinforces this holding of stool behavior. And over time, the colon is going to be stretched out and lose the sensation, so they really don't know when they're going to go. Or just little bits come out, kind of squeeze around that impaction and come out. But again, the child doesn't have control over it. So we've got to determine what's going on. And if they are constipated or impacted, deal with that first. And then sometimes just dietary management, increasing the fluid and vegetables and fruits and, high fiber things can work. We may have to put them on some stool softeners to prevent the constipation. And then we need to break this whole pattern of withholding stool, which then becomes very painful to pass. ADHD. This is a disorder that's characterized by 3 components: inattention, impulsivity, and hyperactivity. The inattention may best be described as distractibility, extreme distractibility. It's not that this child does not attend to whatever they're supposed to be doing, reading a book or writing a math paper. The problem is they attend to everything going on in the room. They're looking at the new shoes the kid in the next desk has. They're looking at what the teacher hung up on the board. They're listening to the sound of the air flowing through the air conditioning vent. They are paying attention to everything, not the one thing they're supposed to pay attention to. The impulsivity, if you ask this kid why they did something, they're going to just sort of hang their head sheepishly and say, I don't know. They really act before they think. It's not intentional. They were anxious to get to lunch, so they pushed everybody out of the way and ran to the front of the line. And then they feel bad, but they do it before they think. And that impulsivity can have some big social consequences. Often these kids have social issues, and it's based on that impulsivity. And then hyperactivity. They can't sit still. They're wiggling and fidgeting. Now, all three of those can have different levels, of how bad that issue is. Hyperactivity can be very little. Particularly girls can be impulsive, inattentive, but not hyperactive. And that's easy for teachers to miss because usually it's the hyperactivity that stands out in the classroom. So these behaviors have to occur in at least two settings. That's usually home and school. And they have to interfere with normal functioning. This kid can't, it's interfering with their learning or with their socializing. So treatment usually is best if you use a multimodal treatment, not just a single thing. So we're going to do behavioral therapy. We're going to write some sort of a behavioral contract with this child. If you do this, this will happen. If you do that, this consequence will happen. So we need to help parents in making those behavioral contracts and in following through with them. Medications. Medications get a bad rap, but for kids who need them, they'll tell you they make a huge difference. The medications we use are stimulants, very similar to caffeine. They stimulate the part of the brain that allows the child to focus. So they're no longer bothered by this distractibility, and they're not as impulsive because they can stop and think before they act. Some of the side effects we have with the medications we use tend to be that they decrease the appetite and they interfere with sleep. Again, very similar to caffeine, right? So we want this kid to eat breakfast before they take their medicine, and they have shorter acting and longer acting, and just depending on sleep issues, it may be a better choice to put them on the short acting, knowing that getting them to sit still to do homework in the afternoon is going to be hard, but they'll be able to sleep at night. The family needs counseling and education. How are they going to do that behavioral modification program? And then the classroom and the home environments need to be changed so this child isn't bothered by all those distractions when they're trying to do their schoolwork. Acne. Most teenagers will tell you they struggle at least for a short time with acne. And this happens because the sebaceous glands become very overactive. They produce tons of oil, which then gets bits of dead skin and dirt in it and plugs the pores of the skin, and then there's germs in there that infect. For most girls, the peak problem age is 16 to 17. For most boys, it's 17 to 18. Contributing factors, this does run in families. So if the parents had a lot of trouble with acne, the children are more likely to. Hormones play a part. And most girls will tell you right before their period is when their acne will flare up. Stress plays a part in it. Cosmetics help to plug up those pores, and then the girls use more cosmetics to hide the acne, which then makes the acne worse. Food studies are not clear-cut on food, but it does seem to have some contributing factor, but primarily dairy products and high sugary foods. So the treatment is general good health. Getting enough rest, enough exercise, eating a balanced diet, decreasing stress. Those things are good for everything, including acne. And then keeping the face clean, but overwashing is not good. So once or twice a day using a gentle face cleanser. And kids who have acne on the forehead or around the hairline, regular shampooing and a hairstyle where the hair is pulled off the face will help. We do have medications out there for acne. You've probably heard of Retin-A. It's a cream or a gel that works quite well, but it makes the skin burn more easily. So we need to advise kids on that to use sunscreen. There's lots of products that have benzoyl peroxide in them, and those also are fairly effective. It won't bleach the skin, but it will bleach their sheets and their clothing, the benzoyl peroxide, so we want to tell kids about that. Prescriptions, we can do topical antibiotics. This is an antibiotic they're putting on their face. If you mix the benzoyl peroxide creams and the topical antibiotics, the two together work better than either one independently works. If nothing so far has worked, we may give them an oral antibiotic, and this is trying to prevent those ones that infect, right? So we're still doing the general good health. With any antibiotic, we're watching for GI upset. Most of the antibiotics we use for this are the ones that cause photosensitivity, so using a sunscreen. And then with girls, you always want to watch for vaginal yeast when you're on antibiotics. They have found that controlling a girl's hormones, birth control pills, will sometimes help. For a girl who's really having trouble, they'll sometimes do the oral antibiotic and combine that with birth control pills. And then the kind of best, most effective medication we have also has the most side effects. So this is Accutane. The treatment is 20 weeks long, and it has to be done by a physician, and it has to be monitored quite closely. It causes some lab changes, dry skin, headaches. It causes mood changes in many children, including depression and can have suicidal thoughts. So they need to be carefully monitored through the treatment for that. It's also highly teratogenic. So if we have a girl on this, we usually require her to be on birth control pills as well, even if she says she's not sexually active, because it will cause damage to a fetus. So obesity. This is defined as body weight where you have excess fat in relation to your lean body mass. The best way to assess is by body mass index, and for doing that, there's a growth chart specific for this. So basically, you're taking the height, the child's height, and the weight, and calculating out their body mass index, and then you chart it on the growth chart by their age. And if their body mass index is greater than the 95th percentile, so this, if they're just super tall and super heavy, they're not going to have a high body mass index. This is the kid who's short and heavy. Body mass index greater than 95th percentile is considered obese. 85th to 95th is considered overweight. And we have about 25 to 30% of children obese now. And there is definitely genetic predisposition. There's also families that have poor eating habits that probably go together. Obese infants are more likely to be obese children, which are more likely to be obese adolescents, which are more likely to be obese adults. We get into this vicious cycle where a child who's obese can't run and play the way the other ones do. So they don't. So they kind of socially isolate themselves. They feel bad because they can't do what other kids can do. So then they eat, which gives them short-term energy, also makes them feel good, but then it contributes to their weight. And so some of the problems we're seeing, which are really new in kids, are type 2 diabetes. An overweight child is more likely to have weight issues as an adult. We're seeing hypertension, hyperlipidemia, cardiovascular disease in children, and then the social isolation and low self-esteem that I talked about. So some nursing considerations, we want to really encourage a good diet and exercise. Get them into a group where they're out playing with the other kids. We do not do the sort of medications that they use with adults, or it would be very rare, and we never do the surgeries. Kids need to be growing. Weight loss surgeries just is not appropriate, would be hazardous for a child. School phobia. This is a child who's afraid to come to school. It's not just they complain and they grumble, but they have an anxiety attack, basically, about school. So we need to get them some help. We need to figure out what's going on, and we need to get them in school, because the longer they stay out, the harder it is to come back. These things will not be on the exam, because you're doing them either in psych or in your med surg.